Hello, everyone, and thank you so much for the opportunity to speak at this wonderful event, the Georgia Wellness Summit. My name is Dr. Randi Smith. I'm a trauma surgeon at Emory University and Grady Memorial Hospital. And today I have the privilege of talking about something that is near and dear to my heart, violence as a public health problem, and specifically talking about a hospital-based approach to intervention. I have no financial disclosures. So as we begin, I think it's important that I disclose upfront that my perspective is a bit unique. The composition of my career is this. It's a combination of trauma surgery, public health, and social science that I achieved through clinical practice, education, and research. I'm an assistant professor of surgery at Emory, and I practice trauma surgery at Grady Memorial Hospital, one of the busiest trauma centers in the country. I teach 2 courses at the Emory Rollins School of Public Health on violence as a public health problem, and also on the epidemiology of firearm injury and death, as well as prevention. And my research largely focuses on investigating the social determinants of health that lead to injury, impact recovery, perpetuate the cycle of violence, and so forth. So as we talk today, I want you to keep this in mind. My lens will always be this unique combination of what I see, what I teach, and what I learned through research, and also what I do. And more times than not, the intersection of trauma and public health for me is injury prevention. So for today's talk, I'll define injury prevention. I will illustrate that violence is a major public health problem, one that requires immediate and sustained attention. I'll discuss a couple of hospital-based violence intervention strategies, and then I'll leave some room for discussion. But first, I want to take a few seconds to pause and let you in on a little secret. Though I have the credentials, I don't call myself an expert on violence. I think of myself more as an advocate. I have a passion, a vested interest in preventing trauma and caring for all aspects of a patient who has experienced a firearm-related injury. I really believe that the experts are those that have the lived experience. And I've just over time learned so much from my patients, some of which I'll share with you today. So I invite anyone who has the expertise, whether it's formal, education, or lived, to please share or add in the discussion. I know sometimes the virtual platform is difficult, but please use the chat and engage during this talk, and I'll be sure to answer questions at the end. With that in mind, I want to put a face and a name to this topic. This is a picture of me not too long ago, and one of my patients, JG. JG gave me his permission to show his pic and share his story. So I just want to, put that out there. But he was born and raised in Atlanta. He's in his 30s. He's married to a lovely woman that I've come to know. And he and I met in February of 2019. For the sports fans out there, you'll probably remember that Super Bowl was held in Atlanta in 2019 in February. So JG, being from Atlanta, he was pumped that the Super Bowl was here in his city. He and his friends had all these plans to go out and party. And one day, as they were heading out, they stopped at a gas station to get some drinks and snacks. They heard an argument happening, but they weren't involved in it. They weren't thinking about it. And then everybody started running. And JG started running towards his car, but then realized that he had been shot. He came to me into the hospital. He was nearly dead from a bullet that had not only gone through his abdomen, but also went through his chest. He needed a bunch of blood. He needed multiple operations. He was in the ICU for weeks and in the hospital for months, but eventually he went home. And when he came to clinic, I was excited to see him because he was doing well. He was eating, he was peeing, he was pooping. These are all the questions that we ask people when they come back to see us in clinic. And I was like, okay, well, should I clear you to go back to work? And he was like, no, doc, man, I can barely get out of bed. And, it was then that I realized he was making tremendous physical progress. He still had a few issues, but mentally he wasn't doing well at all. He reminded me that the consequences of violence are very far reaching. They're exhausting. They extend beyond scars. They touch, not only did they touch him, but they touched his wife and everyone around him. And he wasn't the only one that weekend. That was a particularly violent weekend for us here in Atlanta. This is a clip from a couple of days later. And that weekend really ignited a fire in me to just really dedicate my life to prevention. So what is injury prevention? Injuries are one of the most common reasons for emergency room visits in the United States. According to the CDC, nearly 136 million patients visit emergency rooms in the US each year, and around 30% of those visits are related to injury. It's also very costly, in that in 2019, it was estimated that injuries cost the US $4.2 trillion, and that was in healthcare costs, lost work productivity, lost quality of life, and lives lost. The Centers for Disease Control and Prevention, the CDC, they put out this grid, and it looks at the 10 leading causes of injury death by age group. And what you can see is that there are tremendous injuries from motor vehicle collisions, unintentional poisonings, falls, but firearm-related deaths always make up the top causes, particularly for young people, but it's across the lifespan. Which brings me to my definition of injury prevention. There is a professor, a researcher, his name is Hemingway, and he defines injury prevention as activities to prevent, ameliorate, treat, and or reduce injury-related disability and death. Another definition is effort to prevent or reduce the severity of bodily injuries caused by external mechanisms, such as accidents, before they occur. So one of these definitions says to reduce disability and death, and the other says prevent it from ever happening in the first place. Well, both definitions are correct. There are different levels of prevention: primary, secondary, and tertiary prevention. So I'm going to spend some time here so you can just understand the later parts of this talk. Primary prevention is an intervention that's implemented before there's any evidence of a disease or injury. So if you think about an example of injury prevention, that's primary prevention, it might look like giving helmets to everyone who owns a bike to prevent traumatic brain injury. That's an example of a primary prevention strategy. Secondary prevention is implemented after a disease has begun, but before it is symptomatic. So an example of a secondary injury prevention strategy might be modifying the homes of elderly patients who are prone to falls after you do a screening. And then that will minimize their risk of injury. But again, they're a group that has a condition. You're trying to prevent it from getting worse. And then finally, there's tertiary prevention. It's an intervention after a disease or injury is established, but the intent is really, this is where you want to prevent it from getting worse. So hospital-based violence intervention programs are an example of a tertiary prevention strategy. They are proven effective at reducing risk of recurrent injury and interrupting the cycle of violence. And this is where I'm going to spend a lot of the later part of this talk is focused on tertiary prevention strategies. So until the advent of injury prevention science and really focusing on violence as a public health problem, the thought was that injuries happened because of accidental events. They were unpredictable or unavoidable. But now we are really trying to understand from a theoretical standpoint that it's not really an accidental thing that's happening. We can predict where injuries are occurring. And by looking at the causes, we can actually do something about the problem, and we're shifting the framework. So we no longer say, oh, that was a motor vehicle crash or fatality because of drunk driving. We start asking questions about why. Why this drunk driver and not another? Why did he crash this or she crash this time and not another time? Why this place? Like maybe there's something on the road that contributed as well. And so it allows us to not fixate on changing the fundamental nature of people all the time, but also to take a public health approach and look at the root causes that may lead to injury. We look at this thing called the injury triangle. It was introduced by John Gordon. He's a critical figure in injury prevention theory. He's an epidemiologist that worked out of Harvard. And he studied injury with an infectious disease angle. lending to this critical advancement of injuries as, being the force of three sources: the host, the agent, and the environment. And similar to how infectious diseases are studied. So we realize that if we affect any one of those three sources, then we can play a role in injury prevention. So why incorporate violence into a hospital-based program? Well, violence is a major public health problem. And when we think about what we see in the hospital, we know that over 1 million people between the ages of 18 and 65 experience a non-fatal firearm injury each year. And Georgia, specifically where I am, where we are talking about, it's the sixth highest rate of gun injuries in the US. Again, we start thinking about the cost, and a lot of those costs are hospital dollars, right? And the impact of COVID-19 really did escalate this issue. And gun violence is on the rise. We think back to the 1990s when we were at the height of the crack epidemic and homicides were at an all-time high. And now you look and you see that our numbers have continued to soar. And we're now at these increasing trends where we're getting close to 40,000 individuals that are injured each year from gunshot wounds. Another way to look at it is that 39,000 number is that 109 individuals die each year or each day from firearm related deaths. And the breakdown is that 60% of them are due to suicides, about 30% are due to homicides, and then less than 10% are due to unintentional injuries, which we used to call accidental injuries. And not everybody dies from their gunshot wounds. In fact, non-fatal gunshot wounds outnumber deaths on an order of 3 to 1. So that means that nearly 120,000 people each year must deal with the physical, the social, and the mental health implications that come along with firearm injuries and violent traumas. And unfortunately, not every group in our population suffers from violent injuries the same. There are some significant disparities that exist. This is an example of racial disparities. And I use this slide because when I very first saw this slide, I did not even see the line above the legend. That line above the legend is Black non-Hispanics. They are so far, almost off the chart compared to their white non-Hispanic counterparts. The disparity is quite substantial when it comes to race and ethnicity. There's also gender disparities. So males are that top blue line and females are the black bottom line. And on an order of almost 6 to 1, males outrank females, and when it comes to deaths per 100,000 residents in our population. There's also geographic disparities as well. So this is the map of the US, and the darker the blue, the higher the mortality rate by state. And you can see where we are in Georgia, it's not the darkest blue, but it's pretty darn close. And our neighboring states also are experiencing high firearm mortality. When we start thinking about why that is, the same root causes that lead to firearm injury also include poverty, they include structural racism, homelessness, all these things that are plaguing the southern states. And then sometimes people ask me about Montana and Wyoming. Why those states in the Midwest? Well, remember, this is per capita. This is by the population. So those states are not as dense. And those states also experience a lot of suicides, which makes their rate higher. Now, gun deaths, there's some more recent studies about gun deaths and comparing it to motor vehicle collisions. And about 2011 to 13 is when gun deaths overtook traffic fatalities here in Georgia. And there's a recent study that just came out that showed that this is true now nationally for adolescents, which is very unfortunate. But I bring up this slide because firearm deaths and motor vehicle deaths were two major public health problems. And you can see that motor vehicle deaths were sky high back in 2003. But what happened was that there are so many changes on so many different levels when it came to car safety, road traffic conditions, policy changes, that all really did play a part in seeing that number decline pretty significantly. And I think the most important piece of this was that there was a regulatory body that was overseeing every single level of these changes to make sure that that public health problem was dealt with appropriately. I use this cartoon, and it's a little dated because it's a picture of a Pinto, but it shows, it says only in America where you have a car that there's 27 deaths and then it's recalled. There's some safety measures that had to be looked at. They took the car off the streets in order to make sure that people were safe. And the same was true with drugs. We have a Food Drug Administration that's pretty robust, and they will recall when there are significant deaths related to a drug. But not so much when it comes to guns, right? There's a political divide that has really hindered our forward progress. And this says still going strong after 32,000 deaths per year for decades. And I just showed you the numbers. That number is rising. So you can tell that this is a little bit dated. So specifically in my hospital, we've seen a pretty substantial increase over time in the number of hospitalized patients who have had gunshot wounds since 2009. Now, I'll tell you that we take this data from what we call our trauma registry. It's an institutional database that looks at the number of hospitalized patients who come in. So you have to be admitted to the hospital, hospitalized for more than 24 hours to go into this trauma registry, which means we don't take into consideration individuals that may have a graze wound that may be seen in the emergency room and then patched up and sent home. So ultimately, this is an underestimate of the true incidence of gunshot wounds at our hospital, but still you can see that is pretty significant. So historically, many have viewed gun violence as inevitable or unavoidable, and I'm here to tell you that that is false, right? Gun violence is predictable, it's recurrent, unfortunately. And by recurrent, I mean the same person who is injured by gun violence is then at risk for subsequent injuries. And we know that with every subsequent injury, the risk of death is higher. It's also cyclical. And by that, I mean that the victim is also at risk for becoming a perpetrator of gun violence, thus perpetuating the cycle that I talk about. It's widespread, it's destructive. I mean, it destroys individuals, families, communities, society as a whole. It's very costly, it's devastating, but most importantly, it's preventable. So when we think about the cycle of violence, I think there are some missed opportunities. I'm a trauma surgeon, so I'm talking about me and myself, my group. I think that we are incredibly good at taking care of visible injuries. There have been so many advances in the medical field when it comes to trauma care. Our ability to transfuse patients appropriately with the appropriate blood products, get them to the operating room quickly. Our ICU care is incredible, but we're not comfortable at taking care of those wounds and those injuries that we can't see. So think back to the patient that I talked to you about, JG. I was really focused on his physical recovery, and I wasn't so comfortable with his emotional and his psychological recovery. I quickly learned, and he quickly taught me, but it's something that it takes a concerted effort to become good at it. I don't think that we ask the questions, we don't ask about social determinants of health, those situations and circumstances at home or in your community that might impact your ability to recover or your risk for injury in the first place. And I do think in general, there's this judgment that happens with trauma patients where they're criminalized, where they're treated as somebody who's done something bad or that they deserve this. And we don't treat them like the victim that they are that requires healing. So because we're still learning, this is an opportunity for our growth. Patients are often discharged back to the same environment from which they came. And as I mentioned, there's this high risk of recurrent injury where people who have been a victim of violence are at a 45% risk of a recurrent injury within 5 years. So what's the answer? The answer is that we address gun violence as a public health issue that it is. We think of it just like any other infectious disease, that we can figure out the root causes of why it's happening, figure out where situations are clustered, and then we can promote interventions that can stop the transmission. That's our goal. And this, I love this picture because it looks like cholera in Bangladesh in the late 1980s, 1990s, and 2000s. And then it looks at homicides in Chicago. Both of them use geospatial analysis to look at hotspots. And you can almost superimpose the two maps on one another. We need to treat violence like the epidemic that it is, just like an infectious disease. Well, the CDC has a very easy way to do this. They call it a 4-step approach, where you treat gun violence prevention with a public health lens. And the first is surveillance. The second step is identifying risk factors, and I'll add to that protective factors. The third is adoption of successful prevention strategies. And then the fourth is developing, implementing, and evaluating interventions. So we kind of talked about the public health, the first part of the public health approach, defining the problem. That's all the statistics that we saw, all of the disparities. And so now I want to focus on identifying risk and protective factors. So this is a list of some of the risk factors for violence, and this is by no means exhaustive, right? It's some of the things that we think of: lack of education, unemployment, homelessness, substance abuse. All of those things put you at risk for a violent injury. But the most robust predictor of a violent injury is having a history of a previous injury. That's again where the hospital comes into play, because once somebody is injured, you know that they are at the highest risk. That's why the hospital is uniquely poised to be a part of the solution. Other things on the list that have been studied in the literature include things like adverse childhood experiences, low income and economic stress, exposure to violence, low parental involvement. But again, this list is not exhaustive. On the flip side, there are so many protective factors that we can leverage when we start thinking about interventions. And they include academic achievement, religiosity, high educational aspirations, perceived high expectations from parents. If you think about it, just having parental involvement or some type of parental figure involvement is really helpful in the development of young people. It helps them to develop constructive coping strategies and conflict resolution, and then involvement in pro-social activities like sports, like band, like choir. All of those things are really important. You'll hear me use the term frequently, social determinants of health. And these are the things that I'm talking about, the things that are in our life, in our environment, that really do impact how we live, grow, develop, and thrive. Economic stability, neighborhood and physical environment, education, food, just social interaction, and then the healthcare system. These are all a part of social determinants of health. And so one of the things that we recognize is that risk factors and protective factors are not solely traits of an individual. There's this social ecological model in public health that provides a nested theoretical model that acknowledges that the individual, the relationship of communities and society really does influence the behavior of individuals. And this approach allows for practitioners and for researchers to really build interventions addressing multiple layers of the problem. We also recognize that this is likely a very simplistic understanding of the social ecological model, and it probably looks something more like this or even more complex. But again, when we are addressing this issue, we need to think about it on a multi-layered and multi-tiered approach. So moving on to developing and testing prevention strategies. To combat violence, several trauma centers across the country have established these hospital-based or hospital-linked or hybrid programs. And they created this network where these programs can discuss best practices, some of their successes and failures, and some of the trailblazers in this space are listed here. And You can see Chicago, Philadelphia, San Francisco, Baltimore, Oakland. These are all areas that are plagued with a lot of violence, and setting up these violence intervention programs in the hospital made sense. Well, the group has grown. You can see that there are quite a few programs that are now located on the West Coast and the East Coast, and even some in the Midwest. But what you don't see is a lot of programs in the South and Southeast. The premise behind hospital-based violence intervention programs is that when someone comes in with an injury, recognizing that their injury puts them at highest risk for recurrent injury, we take advantage of what we call the teachable moment. It's the time when people are more likely to enact changes that will really impact their life moving forward. And again, it's not that we want to change the individual. We're trying to understand the circumstances that led to their injury, and together with the individual, change those circumstances. So what we do is we have a case manager or a violence intervention worker, social worker, the name just varies depending on the program, but they come and they meet the patient at the bedside, and they are a supporter from the beginning, from jump. And it's a trust building that happens almost instantaneous when you recognize that someone is there on your worst day or your worst weekend, there to help you so that this doesn't ever happen again. So we heavily rely on intensive case management to understand those risk factors, potentiate those protective factors, and give patients the resources that they need. And then they're shepherded through community resources to aid in their recovery and empower healthy, nonviolent behavior, because we want to reduce their risk of retaliation as well. And we're hoping that they end up getting some, being empowered enough to be involved in the community. I was involved in research on a few different programs that do exactly this. So this is some of the research that I did when I was in San Francisco. And when we looked back at our recurrent injury rates, which in that paper we call recidivism rates, we really recognized that we had a historic recidivism rate of about 16%. That means 16% of people who came in with a violent injury would come back. And when we instituted the program, and we had, we're very modest, we started off small, we had about 254 clients over 6 years. We ended up reducing our institutional rate almost fourfold, down to 4.5%. We looked to see what specific factors, what programmatic features were actually needed to make sure that people were successful. And we found out that mental health and just providing mental health services was associated with a six-fold likelihood of success. And we said success was not being re-injured and actually completing the program. We also realized that if we were able to get people employment, they needed a job, then they were 4 times as likely to be successful. The other piece too was that it really was the interaction with their case manager or their intervention specialist. It was that building of trust and having a peer supporter that was also pretty effective. And so we really used that peer support model and that credible messenger model to spearhead a lot of our efforts. We also did another analysis. We did some fancy methodologies where we looked to see how effective how cost effective the program was. And I will spare you all the details, but just know that when we plugged in how much it cost the program to maintain itself, but also how much it cost the hospital when people came in as a recurrent victim of violence, when you do the math and you put it in this model over a 5-year period, just by having the program and preventing the number of people from coming back and forth to the hospital, we saved the hospital about $500,000. We then did the same thing at another program in the Bay Area, but now in Oakland. And we found out that that program was hugely cost effective as well. And we actually saved the Oakland hospital about $750,000 over that 5-year period. And then finally, we did a mixed method study saying, okay, if this program is hugely successful in the Bay Area, can you just pick it up and put it in another city and make it work? And the bottom line is there are the skeleton is there. The blueprint is there. There are some things that can be exported. You need to have culturally competent case managers. You need to have institutional buy-in. You need to have sustainable funding. But you also have to have the community partnerships and the community buy-in that's going to be unique to your city. So with that being said, here's where we are in Atlanta. And this is, I love this picture. I love the skyline. We're starting what we're calling the IVY project, Interrupting Violence in Youth and Young Adults. It's going to be a program that starts at Grady, and our goal is to start it here to really develop the structure, work out all the kinks, and then to hopefully have it migrate over to the children's hospitals as well, because we partner with them. But we're going to start with adolescent and young adults who've been admitted to our hospital between the ages of 14 and 24 years of age. And they can have any violent injury. It doesn't have to be gunshot wounds, but gunshot wounds, stab wounds, or physical assaults. And our goal is to really start developing a bond with our patients as soon as they hit the door, and to do this intensive case management that's individualized, that's trauma-informed, that's evidence-based, and provide all these wraparound services to them. So we want to make sure that we provide the medical care. We help them, heal from their physical injuries. We also want them to, get a primary care doctor if they don't have one, take care of their wounds and help them with wound care and so forth. But we also want to make sure that we go back to the information that we have from the beginning, right? We know that mental health services are something that are really, really, really important to this group, this vulnerable population. So linking them up with mental health services that start in the hospital and give them access immediately is one of the hallmark features of our program. We also have other things like legal help, education, because again, this is a young cohort, so making sure that they get their high school diploma or GED or some, vocational training, so that they can get the job that they need to thrive. And other services will be provided. And our goal is really the same, to take advantage of that teachable moment after injury when people are hospitalized, do all of the beginnings of case management and learn the risk factors, learn the protective factors, and really try to mitigate and potentiate those respectively. And then after we've had some time with them, do a warm handoff to community-based services so that they can continue to get the wraparound resources that they need, they recover, and they have that community empowerment. Our service wheel is going to be pretty vast. A lot of these things are going to start in the hospital, and then we will move on to the community partnerships that we are developing. And you can see that it extends beyond just the physical illness that they may have been experiencing with their injuries. We plan to have a multi-pronged approach. So intensive case management is going to be the basis, and it's going to be the individual impact. But then we hope that we can have peer mentoring that fosters a sense of community. We want our patients to receive anti-racist and equitable care. So we're hoping that this program will also be a part of a longitudinal educational effort related to trauma-informed care at the hospital level. And then we're, of course, going to evaluate our program, prove that it's effective, and then disseminate our work, because on a national level, we want to put this program on the map. But really, we definitely want to increase the number of these programs that are happening in the South and Southeast, because again, we don't have very many of them. So I mentioned trauma-informed care, and I just want to quickly talk about what it is. Trauma-informed care is the clinical care that understands a response to the various ways that trauma is experienced by patients, families, and staff. And when I say that, a lot of times when someone comes in, I'll give you an example. If a young person comes in and they are a gunshot victim, they've been shot in their leg, they see a lot of bleeding and they're hysterical, instead of saying, oh my God, this guy is agitated, let's just slam them with sedatives, or worse, put a breathing tube in them, really what we need to do is have some reflection in place of reaction. Oh my goodness, this is a young person that sees a lot of blood. Maybe they know someone who's been shot before. Maybe they're in pain. Let's ask questions instead of just being numb to the situation, and be curious in lieu of numbing. And then as a provider, we need to make sure that there's self-care involved in this process. Everybody is at risk for trauma, and it could be other providers, it can be yourself, it also is your patient. So we do need to maintain some type of self-care and practice self-care instead of self-sacrifice. And then the last piece is that we need to be a collective impact. We need to work together and not work in silos. So to remember trauma-informed care, I think of the 4 R's. Realize that there's widespread impact of trauma, and it may be different for everyone, but everyone is at risk. You need to recognize the signs and symptoms of trauma and know that it may manifest in different ways for people. Some people might be completely blank stare, not focused on you at all, not making eye contact. Others might be very agitated, but that might be the way that they manifest their trauma. And to be curious, ask questions, and not just numb to the situation. You have to respond by fully integrating knowledge about trauma into policies, procedures, and practices, and then actively resist re-traumatization. So in the example that I gave to you, if you were to just walk in there and say, this guy is agitated, give him sedatives, slam him with sedatives, that could be re-traumatizing to the patient. That can lead to building mistrust between the patient and the provider. And that's something that we actively need to resist doing. So adverse childhood experiences, there was a study decades ago that happened at a Kaiser in California. And it was for adults that had chronic illnesses like diabetes and obesity. And a questionnaire was sent out to them and said, like, how many of you have, experienced, mental illness, abuse, incarceration, substance abuse? And it was a 10-question survey. And essentially, the bottom line is that experiencing any of the things that you see here, these adverse childhood experiences, can lead to chronic illnesses. And trauma is also, subsequent trauma in your life is definitely something that you're at risk for as well. But if adverse childhood experiences are like the leaves that we see there, I say the soil is going to be adverse community environments, stuff like structural racism, unaffordable housing, joblessness, like all of those things will definitely impact your risk factors and your experiences with adverse childhood measures like abuse and neglect. And then if those are the roots, then the soil is going to be all of the collective historical events like the Holocaust, like slavery, like genocide. And I know that COVID is not behind us, it's not in our history, but COVID has shined a light on so many disparities in our country. I do think that once it is in our rearview mirror, it will be something that's added to this slide. And these are the 6 core principles of trauma-informed care that you see here. So I just want to bring you back to my patient, JG, and he taught me so much. I will say that I learned a lot from caring for him. He's incredible. And he now is back in this space of violence prevention. He talks to young people. He's involved in a community-based violence intervention program. And as we start to develop our trauma-informed program at Grady, the Ivy Project, we're looking to incorporate JG as one of our first violence intervention specialists. So we're very excited for the work that he is and will do in the space of violence prevention. He also is a consultant for community-based participatory research with trauma patients. He has published in one of our premier surgical journals, and I'm just very grateful for all of the insight and education that he has provided me. And this is, you see his name on the author line. he and I co-authored a paper, and it's just incredible to know this partnership has led to him literally becoming an academic. And that's him on the left with some of the intervention specialists from California that are helping us with training and technical assistance. So in conclusion, violence is preventable, and therefore violence intervention should be a part of all hospital-based injury prevention programs. I mentioned this a few times, I'll say it again. Hospitals are uniquely poised to intervene and be a part of the solution of violence prevention. I think that firearm injury prevention is multifaceted, is interdisciplinary, is not just a trauma surgeon thing or an emergency medicine physician thing. It's going to take nurses, social workers, education, schools and law enforcement, everybody working together to try to curb this problem. And I do think that there are some lessons that we can learn from other programs that have done this successfully. And, case management is really at the core, but I do think that we need to make sure that we include individuals with the lived experience. They will be the best peer mentors, because I just think that the trust that's built between them and the patients is almost instantaneous. I think there's a lot of work to be done, but there are so many people who are excited about this work, passionate about it. And finally, there's federal and philanthropic dollars to support the work that we need to do. So I'll leave you with this picture. It's a picture of my little guy. Is the reason why I'm very much interested in developing a peaceful Atlanta and a peaceful Georgia and a peaceful US, because he's growing up and I want him to thrive. And of course, in the spirit of injury prevention, I had to find this picture of him with the helmet on. But here's my contact information, and I'm very grateful to communicate, ask any questions, answer any questions, and work in this space with others who might have an interest. Thank you so much, and I'm happy to take any questions.